Okay, next topic is hairy cell leukemia. It's a rare malignant proliferation disorder of B cells, lymphocytes. It's more common in males and is usually classified as a subtype of chronic lymphoid leukemia (CLL). Hairy cells are abnormal white blood cells with a hair-like projection of cytoplasm. Cytoplasm, not outside like this. Lymphadenopathy is very uncommon in hairy cell leukemia. So, what do you see in the features? Pancytopenia, splenomegaly, skin vasculitis in 1/3 of the patients, dry tap despite bone marrow hypercellularity, also seen in fibrosis. Bone marrow biopsy might show Friedreich appearance, important, and cells with cytoplasmic villi or hairs in the bone marrow, um, spleen and blood, tartrate resistant acid phosphatase trap stain positive. Hairy cell. And presentation classically characteristically occurs in middle age, median age at 50, at presentation is 55 years. Symptoms are variable, gradual onset of fatigue, recurrent infection including mycobacterial infection, left hypochondrial discomfort related to massive enlarged spleen, and hepatomegaly is present in 50% of the cases. Lymphadenopathy is uncommon. Management recent advances suggest good prognosis, and chemotherapy is the first line, cladribine and pentostatin. Immunotherapy is second line, rituximab and interferon alpha. Splenectomy may be effective in reversing pancytopenia. Okay. Next is acute lymphoblastic leukemia, and it's more common in the kids. Acute lymphoblastic leukemia causes damage and death by crowding out normal cells in bone marrow and by metastasizing. ALL has peak incidence at 2 to 5 years old, so it happens only in kids, and another peak in old age. Relatively short course of the disease, fatal in as little as a few weeks if untreated. So features can be initial symptoms are not specific. The signs and symptoms are variable but follow from bone marrow infiltration and or organ infiltration. T1221 is the most common translocation and portends good prognosis. So this is the one, T1221, 1221. Philadelphia chromosome has also a bad prognosis. T411 is the most common in children under 12 months and portends a poor prognosis. Okay. Presentation: generalized weakness, fatigue or anemia, frequent or unexplained fever and infections, weight loss, loss of appetite, and excessive and unexplained bruising. Bone pain and arthralgia can also be common. Dyspnea due to lung infiltration, lymphadenopathy, splenomegaly, pitting edema, and petechia due to thrombocytopenia. So the diagnosis can be leukocytosis, of course, and blast cells are seen on blood smear in 90% of the cases. Bone marrow biopsy is a conclusive proof of ALL. LP to detect CNS involvement, mass. CNS involvement, chest X to look for mediastinal mass, and common in ALL. And urea and electrolyte to look for tumor lysis syndrome. Immunophenotyping establishes whether the blast cells origin in B or T lymphocytes. And DNA testing different mutations reflect prognosis. Treatment can be remission induction phase, intensification phase, continuation therapy to eliminate residual disease. The only exception is patients with mature B cell ALL, where short-term intensive chemotherapy, including high-dose methotrexate, cytarabine, and cyclophosphamide. So prognosis: children respond well to treatment, and 95% achieve complete remission. 50 to 60% of whom are cured with post-remission chemotherapy. Adults 80% achieve complete remission, 35% achieve long-term disease-free survival. So good prognosis factor will be common ALL, pre-B phenotype, low initial white blood cell count, and FAB L1 type. And L3 type is the poor one. T or B cell markers, Philadelphia translocation, less than 2 or more than 10 years. Male, CNS involvement, white blood cell count more than 100, non-Caucasian. TET is present in 90% of ALL. Okay. So before treating with chemotherapy, if blast cell is very high, more than 100, the patient needs leukapheresis to prevent sludging of capillary beds. This can be life-saving. Hodgkin's lymphoma is a malignant proliferation of lymphocytes. It's a proliferation of lymphocytes and characterized by a presence of Hodgkin and red stromal cell. This is the main thing. It has a bimodal age distribution behind being most common in the third and the 70th decades. Hodgkin's lymphoma is associated with EBV as well. So EBV. 25% have constitutional upset like night sweats and weight loss, fever, pruritus, lethargy. HRS have been recently identified clonal B cell that lack type B cell surface antigens. So the staging of Hodgkin's lymphoma, very common question. Stage 1 is single lymph node. Stage 2 is 2 or more lymph nodes regions on the same side of the chest, 2 or more on the same side. 3 nodes on both sides of the chest, so both is 3, the diaphragm, and beyond lymph nodes. A is no systemic symptoms other than pruritus. B is weight loss more than 10% in the last 6 months, fever, night sweats, fevers, night sweats, and weight loss. So for ALL, the poor prognosis factors are age 45, stage 4 disease that is spreading beyond lymph nodes, hemoglobin less than 20.5, lymphocyte count less than 600, male, albumin less than 40, white blood cell count 15,000. Night sweats are a feature of non-Hodgkin's lymphoma. Okay, non-Hodgkin's lymphoma. So this is more into non-Hodgkin's lymphoma, and then okay. So it also is included with poor prognosis. Okay, diagnosis: Hodgkin's results in patchy bone marrow infiltration, and isolated bone marrow biopsy may yield non-specific results. Bone marrow biopsy is more useful for staging of advanced disease. Lymph node biopsy would be more likely to be positive for red stomach cells. So, management: majority of localized and advanced Hodgkin's lymphoma can be treated easily, successfully. Early stage 1A or 2A are effectively treated with radiation and chemotherapy. So start with RC. Choice of treatment depends on the age, sex, bulk, and histological subtype of the disease. Later disease 3, 4, 4B are treated with combination of chemotherapy alone. Large mass in the chest are usually treated with combined chemotherapy and radiation. Chemo includes ABVD, atriamycin, bleomycin, vinblastine, dacarbazine, and other cytotoxic drugs. Okay. So high dose chemotherapy followed by autologous stem cell transplantation can be regarded as the treatment of choice for patients who have relapsed following treatment. Types of Hodgkin's lymphoma. Classical Hodgkin's lymphoma can be subclassified into 4 pathologic subtypes based upon red stomach cell morphology and composition of the reactive cell infiltrates seen in the lymph node biopsy specimen. So nodular is the most common subtype and is composed of large tumor nodules, scattered lacunar classical red stomach cells set in the background of a reactive lymphocyte. So red stomach plus lymphocyte background. In the background of reactive lymphocyte, eosinophil and plasma cell with a varying degree of collagen fibrosis sclerosis. Okay. And mixed cell type is a common subtype and is composed of numerous classic red stomach cell and mixed with numerous inflammatory cells including lymphocyte, histiocyte, eosinophil, plasma cell without sclerosis. This type is most often associated with EBV and infection and may be confused with early so-called cellular phase of nodular sclerosing. So it's good prognosis. Mixed is good. And lymphocyte rich is the best prognosis one. The rare subtypes show many features which may cause diagnostic confusion with nodular lymphocyte predominant, B cell non-Hodgkin lymphoma. Best prognosis. Lymphocyte depleted is the worst one. Rare Selly subtype composed of large number of often pleomorphic red stomach cell with only few reactive lymphocyte, which may easily be confused with diffuse large cell lymphoma. Many cases previously classified within this category would now be enriched and reclassified and under anaplastic large cell lymphoma. Worst prognosis. Nodular lymphocyte predominant Hodgkin's lymphoma versus C20 and is not currently considered a form of Hodgkin's lymphoma. Okay, so non-Hodgkin's lymphoma. It's a diverse group of lymphomas that include any type of lymphoma except Hodgkin's. And so types of NHL vary significantly in their severity, from indolent to a very aggressive. Low-grade lymphoma is predominantly a disease of older people. Most non-Hodgkin's lymphomas are B cell, 90%, and the remainder are T cell, like our natural killer cell. So etiology can be of most NHL is unknown, and possible etiological factors can be EBV linked to Burkitt's lymphoma, herpes, human herpes virus 8 related to diffuse large B cell lymphoma, HIV associated NHL, H. pylori, gastric malt NHL, hepatitis C. So most present with advanced disease, bone marrow infiltration being almost invariable. Extranodal presentation is more common than Hodgkin's disease. Um, Renal impairment in non-Hodgkin's lymphoma usually occurs because of ureteric obstruction. Ureteric obstruction secondary to intra-abdominal or pelvic lymphadenopathy. Anemia, increased white cell or thrombocytopenia are sensitive of bone marrow infiltration. So it's renal and blood, of course, blood. Lymph node biopsy is sufficient for definitive diagnosis. It's essential for modern classification to submit the lymphoid tissue for immunophenotyping and cytogenic molecular analysis. High-grade lymphomas are responsive to chemotherapy and potentially curable. Low-grade lymphomas are incurable with conventional therapy. Chemotherapy is the mainstay treatment. Okay. Next is Burkitt's lymphoma. It's a high-grade B cell neoplasm. There are two major forms. Endemic African form typically involves maxilla or mandible like this, and sporadic form abdominal, ileocecal, and ovarian tumors are most common form. Okay. More common in patients with HIV. Burkitt's lymphoma is associated with CMYC gene translocation, usually T814. The EBV is strongly implicated in the development of the African form, but the link to sporadic Burkitt's lymphoma is less clear. So Burkitt's lymphoma is a common cause of tumor lysis syndrome. Management is with chemotherapy. This tends to produce a rapid response which may cause tumor lysis syndrome. So what is that again? This occurs after the initiation of a chemotherapeutic. TLS tends to occur in patients with bulky, rapidly proliferating treatment-responsive tumors. Association acute leukemia, high-grade non-Hodgkin lymphoma, pre-treatment LDH increase. Manifestation can be rapid development of 42 hours of hyperkalemia, hyperuricemia, hyperphosphatemia, so acute renal failure. So potassium, uric acid, phosphate all will increase, but calcium will decrease. And ARF11, AKI. So basically what happens is the cancer cells die and they release potassium, uric acid, phosphate. That's what happens. And management can be prevention. Treatment is with good hydration, 3 liters per meter square before starting chemotherapy, and increased uricemia, urine alkalization, allopurinol raspuricase may also be used. Osmotic diuretics are not first-line therapy and may contribute to the precipitation of uric acid in the renal tubules. Dietary modification include restricting dietary potassium. Further chemotherapy should be withheld until the patient has full recovery. Okay. Waldenstrom's maculoglobulinemia. It's an uncommon condition seen in older men. It's a lymphoplasmacytoid malignancy characterized by secretion of monoclonal IgM paraprotein. So it's IgM only. So monoclonal IgM paraproteinemia, systemic upset, weight loss, lethargy, hyperviscosity syndrome like visual disturbance, headache, hepatosplenomegaly, lymphadenopathy, cryoglobulinemia, Raynaud's ASR. Management can be alkylating agents. Young patient may benefit from doxorubicin. Treatment includes the monoclonal antibody rituximab, sometimes in combination with chemotherapeutic such as chlorambucil, cyclophosphamide, or vincristine. Corticosteroids such as prednisone may also be used in combination. Plasmapheresis can be used to treat the hyperviscosity. So many things are there. Those treatment. Doxorubicin, rituximab. Next is monoclonal gammopathy of undetermined significance. Monoclonal gammopathy of undetermined significance, MGUS, also known as benign paraproteinemia, and monoclonal gammopathy, is a common condition that causes paraproteinemia and is often mistaken for myeloma. So, differentiating features are listed below. Around 10% of patients develop myeloma at 5 years, with 50% at 15 years. One of the key differentiating between MGUS and myeloma is the absence of clinical complications such as immune paresis, hypercalcemia, and bone pain. So usually asymptomatic, no bone pain or increased risk of infection, and 30 to 20 to 30% have a demyelinating neuropathy. M protein level less than 30 gram, no end organ damage. Management serum protein, protein and less than 30 gram, and coronal plasma cell less than 10, and no bone marrow biopsy, and no myeloma related organ tissue impairment. What is this? Okay, multiple myeloma, the important one, is a neoplasm of the bone marrow plasma cell. The peak incidence is 6 to 70 years old. Bone pain, osteoporosis, plus pathological fractures, osteolytic lesions, lethargy, infection, hypercalcemia, renal failure, amyloidosis, other features, macroclosure, carpal tunnel syndrome, neuropathy, hyperviscosity, all these. Diagnosis: monoclonal proteins in the serum and urine, Pence-Jones proteins, increased plasma cell in the bone marrow, bone lesions on the skeletal survey, lytic lesions. Other features, findings on investigation, rouleau formation on red blood cell and blood film. Okay, for part 2 this is what can be interesting. Definition of active multiple myeloma: clonal bone marrow plasma cells more than 10%, or biopsy proven bony or extramedullary plasmacytoma, and one of the following RAP features, and myeloma defining events. Evidence of end organ damage that can be attributed to the underlying plasma cell, to proliferative disorder, especially hypercalcemia, renal insufficiency, creatinine clearance less than 40, serum creatinine more than 2 mg per dl, anemia, hemoglobin less than 100, was 10, one lesion, more than one osteolytic lesion on skeletal radiography, CT or PET CT. Okay. Any of the following biomarkers of malignancy: more than 60% coronal plasma cell on bone marrow examination, serum involved, uninvolved, free light chain ratio more than 100, provide the absolute level of the involved light chain is at least more than 100, more than one focal lesion MRI. So MGUS, multiple myeloma, plasma cell in bone marrow more than 10%, and myeloma defining event, chance of progression to cancer, treatment, no observation, this observation, and this there is treatment. And the difference between the MGUS and multiple myeloma is this: immune paralysis, hypercalcemia, bone pain. Okay, high risk criteria for smoldering multiple myeloma: plasma more than 10%, M protein more than 3 gram. All these risks are there. Part 2: calcium elevation, renal complication, anemia, bone disease. Okay, beta 2 microglobulin is a useful marker of prognosis. Raised levels imply poor prognosis. Low levels of albumin also associated with poor prognosis. So, increased beta 2, decreased albumin, poor prognosis. Okay, then staging is there. The stage 1, beta 2 microglobulin less than 3.5, survival months 62, not 1 or 3, 45, and more than 5.5 is 29. So these are the main thing. So initial therapies are there: high dose chemotherapy, then prior stem cell transplantation, induction chemotherapy, then autologous stem cell transplantation. All these are there. Not going through the full thing. Patient with myeloma with or without evidence of bony disease should be on bisphosphonate. It's good for bony pain symptoms. And hyperviscosity can go for plasma exchange. Acute renal failure is reversible, but chronic is irreversible. Okay, maintenance therapy is there. All that. Okay, so all these are part of part 2 thing. Rouleau are stacks of red blood cells which form because of the unique discoid shape of the cells in vertebrate body. The flat surface of the discoid red blood cell gives them a large surface area to make them contact stick to each other. Okay, so they occur when the plasma protein concentration is too high, and because of them the ESR is also increased. This is a non-specific indicator of the presence of disease. Conditions which cause Rouleau's formation includes infections, multiple myeloma, inflammatory and connective tissue disorder, and cancers. Also occurs in DM and is one of the causative factors for microvascular occlusion in diabetic retinopathy. Okay, hypercalcemia and myeloma due primarily to osteoclastic bone resorption caused by the local cytokines reduced by the myeloma cells. Other contributing factors include impaired renal functions, increased renal tubular calcium reabsorption, and elevated PTH-RP level. Okay, extravasation of chemotherapy. Extravasation should be suspected if a patient complains of pain, burning, swelling, or redness at the side of the infusion cannula. Immediately stop the infusion, immobilize the arm, and attempt to aspirate any accessible drug from the cannula and extravasation site before removal of the cannula. Agent-specific antidotes can be given after receiving specialist advice. Cold compressions and are generally applied except in the case of colloid. Doxorubicin, ranorubicin extravasation injuries are particularly prone to causing ulceration, particularly on the back of the hand, and hence a plastic surgery consultation is likely to be needed. Using topical corticosteroid to treat the site of inflammation, consider reporting it to the national extravasation. Blah blah blah. Okay, veno-occlusive disease or hepatic veno-occlusive disease is it's a complication of high-dose chemotherapy given before a bone marrow transplant. The name sinusoidal obstruction syndrome is now preferred if VOD happens as a result of chemotherapy or bone marrow transplantation. Treatment is primarily supportive. Features can be fluid retention, hepatomegaly, bilirubin increase, multiple organ failure. Ultrasound abdomen helps in diagnosis. Hematological infections and malignancies. Okay. Viruses, EBV, Hodgkin and Burkitt lymphoma, nasopharyngeal carcinoma, EBV, HTLV, adult T cell leukemia, HIV, high grade B cell lymphoma, bacteria, gastric lymphoma, MALT, Ellery Burkitt's lymphoma. Okay, moving to the next part. Some medicines are there. You have to know the mechanism of action or adverse effects, and also the notes on bone marrow transplant. So, stem cell transplants from unrelated or haploid identical donors are not used in first complete remission in most adult hematological malignancies. Due to high treatment-related mortality or morbidity, they are reserved for first relapse, second complete remission. Stem cell transplants from matched sibling donors are used as the first line therapy in certain circumstances, including CML. Irradiated blood is required in patients receiving a bone marrow transplant, patients with previous purine analog exposure, and the diagnosis of Hodgkin's disease. Irradiated blood is needed. Cytomegalovirus negative blood should be used in patients who may need bone marrow transplant in the future. Imatinib is targeted to inhibit the novel tyrosine kinase that is formed from the genetic translocation between chromosome 9 and 12, which is the hallmark of CML. Imatinib mesalate is used as the first line therapy, being about blah 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 blah, so many things. Okay, in summary, in the absence of siblings, imatinib to use. If patient had siblings, related stem cell transplant may be considered. So first you give imatinib if there is no siblings. Okay, so common drugs. So common translocation to remember is T922 Philadelphia chromosome. More than 95% patients with CML results in BCR-ABL, and it encodes for a fusion protein which has tyrosine kinase activity in excess or normal. So poor prognosis indicator in ALL and AML. So this is in CML, but it's poor prognosis indicator for these two acute ones. T1517 we already studied that, seen in acute promyelocytic leukemia M3, fusion of PML and RAR alpha genes. Okay, T814 Burkitt's lymphoma MYC gene is translocated to an immunoglobulin gene. T1114, 11 is mental cell lymphoma, deregulation of the cyclin D1 BCL1 gene. Vincristine inhibits formation of microtubules and mitosis inhibitor M stage of cell cycle. Peripheral neuropathy, reversible constipation in elderly. Cisplatin causes cross-linking in DNA, autotoxicity and hypomagnesemia. And bleomycin, lung fibrosis, degrades preformed DNA. Doxorubicin stabilizes DNA, topoisomerase 2 complex, inhibits DNA RNA synthesis, cardiomyopathy, very important question. Keeps on coming in the exam. Methotrexate myelosuppression, mycocytosis, inhibits dihydrofolate reductase and thymidine synthesis. Cyclophosphamide alkalizing causes cross-linking in DNA, same as cisplatin. Hemorrhagic cystitis comes often. Incidence decreased by hydration and suppression. Translucent carcinoma. Docetaxel prevents microtubule depolarization, and the